I'm really working on making sure that patients understand their own anatomy and understand their own physiology, meaning how does their body work? So, what are my body parts? How does it work? And what's actually happening when things go wrong? So that when they go in, they can actually advocate for themselves in the doctor's office. Because unfortunately, doctors aren't incentivized to learn this.
What if the reason so many people are suffering from chronic sexual health conditions is because they've been misdiagnosed all along? This is such a powerful conversation with Dr. Maria Uloko. We talk about why vulvar health is widely misunderstood, how medical education is failing patients, and what it takes to advocate for your own body. Dr. Maria Uloko is an internationally acclaimed urologist and sexual medicine specialist, known for her groundbreaking work in vulvar health, menopause, and regenerative sexual medicine. Her work has been featured in publications like Forbes and the New York Times. She's a global educator, researcher, and advocate working to transform how clinicians diagnose and treat sexual health conditions while empowering patients to better understand their own bodies. If you're ready to rethink everything you thought you knew about sexual health and feel more confident advocating for your body, this is the conversation you don't want to miss. Welcome to Sexology Lab. Each week, we speak with the most compelling minds in modern sexology to ask the questions shaping the future of desire, connection, and human wellness. Let's dive in. So I want to start out with a question for you. If you could change one thing about how most clinicians currently approach vulvar health and sexual health, what would it be?
That is a heavy question. I think the first thing I would change is really waking up a lot of physicians to understanding that we were not trained on the intricacies of the vulva. Many physicians graduate training and leave training and are actively seeing patients without understanding the unique physiology, meaning how does the vulva work? What are the specific parts? What does each part do? And there's so many reasons for that. I mean, we can just talk about medical misogyny and medical sexism and how it impacts medical education. But then also the other thing is the lack of research. There has been a paucity of research around vulvovaginal health care. And, gynecologic research tends to skew more towards obstetrics, which is really, really important. But in that, we've lost a lot of the scientific integrity and the real scientific meat and yumminess of the vulva. So that's where I would start first is for a lot of physicians, you don't know what you don't know. And I think we all go through training thinking that we're learning about the vulva. But really, what I found out in my own experience and then the research is that we're not being taught the intricacies. And so then we leave training, start seeing patients without understanding how important this structure is. It's not just the vulva, it's not just the thing that's leading to the vagina. It's each part has its own way it works, how it stays healthy. And there's just so much beauty and science and richness just in this one structure that it's made out of many multiple structures.
Oh, I love that. So what you're saying is it's about more than just having babies?
Yeah, so turns out that is not the only reason that we were put on this earth.
Turns out.
It is like truly a miracle to have a child and to bring in birth life. And it is one of the most miraculous things. But then what happens after that's over? Our healthcare shouldn't stop with childbirth. When we're past birthing, people need access to care and science at every stage of their life. And we really have to start changing the narratives. And I think the hardest part is that most physicians aren't even aware that we're not getting the right training. I'm just such a big believer is you don't know what you don't know. And really, it's the governing bodies, ACOG, CREOG, the people that determine what people learn should actually be the ones really reassessing the curriculums and reassessing how they're training physicians leaving the healthcare system. American Medical Association, I'm calling y'all people out because it's like you're the ones that are training us. And if you're not training us to even know the intricate parts of the system, we're missing so much. So much disease. We're misdiagnosing patients at really high rates. And really, the only people that are suffering are patients. And that's the thing. That's why I will never stop speaking about this, is because I've just seen so many patients suffering from such easy reversible diagnosable conditions and they've been told they're incurable, when really all they needed was a very detailed vulvar exam and understanding of how the vulva works and then how to fix it when things are not unhealthy.
Oh, absolutely. So now I want to know how you got so passionate about this. So in about 30 seconds, and it can be longer, but I want to know, what's your origin story? So how did
Yeah.
you find your way into this work, and when did you realize this is my specialty?
Yeah, serendipity. My whole life has been around serendipity. I was born in Nigeria. We were one of the first immigrant families to win a visa lottery. Literally, we won the lottery to come to America. That is wild. And so my whole life has been around just full of magic. Did I know that I was going to become a urologist? No, I grew up a poor Black kid in the inner city of Kansas City. Like, I didn't even know I could become a physician or yet alone a surgeon. I didn't even know what a urologist was. And so it was just a series of very fortunate events. I have very strong ancestral guardians always
Yeah.
watching out for me. And I got into medical school at 17.
Wow.
Yeah,
I
that
never
was a
knew
whole
that
thing.
about you. That's amazing.
Yeah, I'm like a hotter, blacker Doogie Howser. I got into medical school at 17. Like, I didn't know anything. I just knew I got into medical school. And then I found urology on a whim, like really one of my last rotations. I knew I liked urology, got into the field, was told I couldn't get into the field and got into it. One of the things about me is like when people tell me I can't do something, I'm immediately going to do it.
I hear
Um,
that.
I'm learning to not do that and just actually follow the beat of my own drum. But got into urology, really loved the long-term care of patients. And what I really loved about it is that we could take care of patients from cancer to childbirth, like from cancer
Mhm.
to infertility. And I think one of the things I really loved about this was the quality of life. Like, we could treat your cancer, and then after we treated your cancer, we can then treat the erectile dysfunction that happened after it. I got to really
Yeah.
see the impacts of quality of life on these patients. And so I did a sexual medicine fellowship, truly again on a whim. I was at the University of Minnesota for residency, hated the cold, and I
Mm.
just wanted to be warm for like the first time in like 5 years. And so I did a fellowship at San Diego Sexual Medicine with Dr. Erwin Goldstein. And I literally just wanted to be in San Diego for a year. And
Yeah.
I like that fellowship changed my life. That is the only urology fellowship in the country that does men, women, transgender, all genders. Yeah, that totally changed my life because I grew up without access to care. I've always been very passionate about making sure that people have access to care. I ran a free health clinic when I was in medical school. I've always been really passionate about health disparities. And I realized that sexual health between the sexes and your gender identity, your gender expression, your genitalia actually impacts how you get healthcare.
Mm.
And when I say women's health is a public health crisis, it is a public health crisis. And I can say that very confidently because I trained as a urologist. Men were my standard of care. I had a lot of privilege, I had a lot of access, and I didn't even know that I had all of those things because I just
Mm.
assumed that's what all specialties had, especially surgical specialties. And then when I went into women's health and women's sexual health and female sexual dysfunction, I realized that like, oh no, like there are so many patients suffering from very treatable conditions. 85 million women in the US alone are suffering from chronic vulvovaginal conditions. It takes
Mm.
7 years to get a diagnosis, three or more doctor's visits, and then over $20,000 out of pocket costs just
Oh
to
my
get the right
gosh.
diagnosis.
Wow.
And it's sitting with these patients and hearing these stories over and over again where you're like, you can't help but get mad. You can't
Hmm.
help but understand that 50% of the population just doesn't get the access to good, credible scientific care just because of medical misogyny and medical sexism and the poor medical education system that's churning out physicians who aren't being trained on this. And we have so much data and so much resources. I'm not just talking out of my ass. I'm literally quoting like
Yeah.
I'm quoting science. I'm quoting the data. So much data shows that physicians are not comfortable with female sexual dysfunction. They're not comfortable with female anatomy. They're not comfortable with, vulvar vaginal anatomy, physiology, diagnostics. This isn't new. However, no one's really been doing anything about it. And I think because I am so few of so many, and there's only 7 of me so far, and there's billions of vulvas in the world. And so
Yeah.
like you realize that like you need the whole cavalry. Like it can't just be you. It can't just be you claiming this. You need a whole network of people to start doing this advocacy work. And it's patients, it's doctors, it's scientists, it's researchers, it's sex and sexuality advocates in order to change a system that refuses to change. Oh, so I
Wow.
think that was 30 seconds.
I think, about 30 or so. No, that's really incredible. I loved hearing your origin story. Thank you for sharing that. All right. Now, I want to know, what is one current shift or trend in sexual health that genuinely excites you right now?
What I love about this work is how close I get to work with patients and patient advocacy groups. One of the coolest things that I have seen in this work, particularly around vulvovaginal pain and pelvic pain conditions, is that patients aren't taking it anymore. Like they are literally saying, you can't not treat us, you can't not
Yeah.
diagnose us. And there are amazing patient advocacy groups. My particular favorite one is because I work so closely with them. It's Tight Lipped, where literally people suffering from vulvovaginal conditions across the country got together and are doing grassroots organizations where they're literally going into OB-GYN programs and teaching them the impact of gynecologists and physicians, large physicians, it's not just gynecologists, it's all physicians, the impacts of what it means that you're leaving training without knowing how to diagnose these conditions, and then also bringing in physicians to help teach you how to diagnose. Like these are people with real full-time jobs, and yet they're the
Yeah.
ones that are knocking on the door and saying, you can no longer not treat us. Like you have to start treating us and you have to start training your doctors on how to treat us. And I love partnering with them and I love amplifying their message because I'm only one person and there are
Right.
many physicians in the space trying to like change it. It's this beautiful merger of physicians and patients working together for a bigger change. That's something that I'm obsessed with. And I
Yes.
will always lend my voice and my power to organizations like that.
Oh, I love it. That's so incredible. Now, if you could teach the world one essential insight about sexual health, something that really moves the needle, what would that be?
The fun fact, the vulva has the capacity for regeneration. You can have the same vulva at 20 at 100 years old. It is optimal vulvar health. The vulva is dependent on hormones, and our vulva is constantly changing. Literally, with every cycle, our vulva changes. Every life phases, our vulva changes. But the beauty of this is that those changes, which can be dangerous and can have really bad impacts and cause pain and an infection and sometimes death, like recurrent UTIs can also be caused by poor vulvar health.
Mm.
We could be preventing all of this. There's no reason as to why we allow this very vital tissue to become diseased and unhealthy. Like we
Yeah.
have the medications, they're there, they're available. It's just now the advocacy around this. And so that's my favorite fact to tell people is that you can have the same vulva at 20, at 100 years old. It's just optimizing our vulvar health because that not only helps our sexual health, and like that's very important, but some people don't want to have sex, and that's absolutely fine. But it also optimizes your bladder health. We have new research that was just accepted and it's going to be published in the coming months that showed a link between poor vulvar health and unhealthy vulva and recurrent UTIs. So your
Mm.
vulva is directly linked to your bladder health. So many people are suffering from recurrent urinary tract infections, especially after sex. And they think it's something in their urinary system, their kidneys, the tubes that drain their kidneys, or something in the bladder. But actually, a lot of those symptoms can be coming from the vulva. And so,
Yeah.
if we actually knew how to examine the vulva, we knew how to keep the vulva healthy and be able to spot disease early, we could be preventing UTIs. And so,
Mm.
that's something that I will keep screaming from the mountaintops because I've had so many patients that have come to me with debilitating UTIs. We find out that it's just the vulva. We know that there's amazing, cheap, fun medications that we can and repair the vulva, and they never have UTIs again. Like that is,
Wow.
we're able to give people their life back just with
Yeah.
simple science and having an algorithm and knowing how to use it.
Mm. Okay, so now I'm going to go off script here. So I'm a mom of three, and two of those
Yes.
children are my daughters. So as a mom, what should I be teaching my young daughters? They're 8 and 11 right now about vulvar health.
Yeah. I love this question because it touches such a nerve for me. I remember I grew up in a family where having female genitalia was shameful. I still remember the
Mm.
conversation I had when I got my period for the first time,
Yeah.
and my mom told me this is the most shameful secret. Don't tell anyone. And I was like,
Wow.
I feel like that's not right. Like I was
Oh
like 10 or
no.
11 and I was like,
Yeah.
yeah, that can't be right. And like I
No.
think she also told me like if a boy touches me, I'll get pregnant. I was like, oh, this lady doesn't know
Oh.
anything.
Oh no.
What it is that's actually generational trauma. That's the
Mhm.
generational trauma because that was a conversation that she probably had with her mother and
Yeah.
her mother and her mother. And I see that generational trauma all day, every day. Whenever I do an exam for someone coming in with vulvar issues, whether it's pain, infection, difficulties with arousal sensation, when I do an exam, almost every single patient apologizes for their body. That is ingrained culturally. When I have male patients or patients with penises, they don't apologize for their bodies. They're not like, oh my
No.
God, I'm so sorry you have to see this. They're like, okay, like drop trowel, let's go. Like, but every single patient with a vulva that I have to do an exam on apologizes for their body. That is the culture of shame. And
Yeah.
so one of the things I would talk to your kids about is not being ashamed and not being afraid of their own body parts. I think the way that we have shaped the conversation around the vulva and sex and sexuality and female sexuality is rooted in shame and rooted in this kind of like anti-science. And so I think shame begets for education begets more shame. Like it's this like
Yeah.
never ending cycle. Starting out talking to them about their vulvas from a place of power. Like there's
Yeah.
no other part of the body that is able to regenerate like that. Because I do regenerative therapy
Yeah.
research and I've never seen stem cell, what happens in the vulva. Like that's
Wow.
unreal. There's magic there. And yet
Yeah.
we are so shamed about it. And so, yeah, that's what I would tell them is just, yeah, be proud of their vulvas and like educate them on the different parts and just not to be afraid of it. Because I think
Mhm.
the shame begets so many issues down the line. And if we can
Yeah.
combat that early, we're going to save them so much time.
Oh, I love that. That's great advice. Thank you. Are you curious about sexology? Do you want to further integrate sexology into your work or your life? Well, friends, then we've got something just for you. It's called the Sexology Practice Guide, and it walks you through the ways this shows up in your work, in your life, and guides you through working within your scope, incorporating intimacy and sexual health into your work without starting over. Download this short, practical guide at sexologylab.com/guide. That's sexologylab.com/guide. And while you're here, make sure to subscribe and share. And now, back to the show. Now, at Sexual Health Alliance, we train many people who are wanting to work in sexual health. What is the most important thing professionals need to know about this space?
I think one of the things that I really love telling people is that a lot of the diseases that we've labeled chronic pelvic pain, chronic vaginal infections, recurrent UTIs, chronic UTIs, they're not chronic for most people. We, as the healthcare community who have the responsibility of providing accurate diagnosis, are just not being trained on how to diagnose. So instead, what we do is we say, wow, you're still having pain, must be a chronic condition. Here you go. My colleagues in the sex and sexuality space, my sex therapists, my pelvic floor physical therapists, my sexual educators are then taking on the burden of a patient that has been misdiagnosed with a chronic condition when really they just have a misdiagnosis. And so I want to tell my sexual health team that if someone gets a diagnosis of current of chronic, start thinking maybe I want us to change that paradigm. I want us to change that narrative that a lot of the diseases aren't chronic, they're misdiagnosed. And the reason
Mm,
why I want to change the language matters here is because there have been so many studies that look at the perception of disease. If someone believes that they have a chronic disease, it absolutely changes their outcome versus if someone believes that you have a symptom, that symptom is caused by this biologic reason, and we can fix and cure that symptom. They have a whole different outlook on their disease state, which then has an impact on the cure rate. Your mindset actually does impact how you perceive your diagnosis. And so if we're telling people you're chronically have this condition when they really don't have a chronic condition, that's so bad. It's so unfair. It's just so unfair because then that person, that's their whole identity. It becomes that.
yeah.
And they then have to work to like fight to not make that their identity when that was never the label that they deserve. That's what I like to tell my teammates is that a lot of the diseases that we're calling chronic, they're really just misdiagnosed. And if
Mhm.
we can start framing that narrative and reshaping that narrative, I think we would really help a lot of patients get better. There's such a difference between, hey, this is just a moment in time, it's going to
Yeah.
pass, versus this is something you're going to have to live with for the rest of your life. It really messes
Yeah.
with people's brains, spirits, souls. Like it's a whole thing. And so that's what I like to share with my colleagues is that there is hope. There's so much hope. I love
Yeah.
hope.
Right. Yes, I know. That's what I'm thinking too. Like, when you tell somebody, oh, like this is chronic, you're going to have this forever, there's a sense of hopelessness, and
Yes.
that is no way to live your life when there's something you could do about it. You just have to find
Yes.
a provider who understands.
Yeah, yeah. And that's what I'm working on is making sure that providers understand. Actually, I'm really working on making sure that patients understand their own
Mm,
anatomy and understand their own physiology, meaning how does their body work? So what are my body parts? How does it work? And what's actually happening when things go wrong? So that when they go in, they can actually advocate for themselves in the doctor's office. Because unfortunately, doctors aren't incentivized to learn this. And I will always hold space for my healthcare colleagues. The healthcare system is in a crisis. They
yeah.
don't have capacity to learn more, do anything. It's on fire right now. So I understand the narrative of why should I learn this? I understand it, but I also don't think it's right. And
Hmm.
so I spend a lot of time trying to teach doctors and train doctors, but I realize that a lot of them are reluctant as of right now to adopt new ideas, new anything. And so I realize where my time is best spent is educating the patient so that they can become
Yeah.
their own advocates. And then they can start pushing the healthcare system from inside the system. That's what I do. A lot of my work around the company that I own, Vulva AI, is
Yeah.
how can I educate the patients so that they can become their own healthcare advocates?
Yeah, absolutely. So I want to talk a little bit more about the medical professionals that you work with. So when you look at how they're practicing, what are they doing right and what are they missing?
It's hard to say what are they doing right. And I have to go back to you don't know what you don't know. And it's a culture thing. First and foremost, it's a you don't know what you don't know. And then secondly, it's a culture thing. There exists a culture of medical misogyny. There exists a culture of patients suffering from vulvovaginal conditions, pain, or infections over this. They have a negative connotation in the medical field. It's a culture issue. Women's pain has been historically dismissed throughout
Yeah.
all of medicine,
Right.
it's not them, that person, that medical student that comes in bushy-tailed and bright-eyed and excited to learn is now learning from a doctor that's saying things like, ugh, that patient, they have pain. Ugh, they'll never get
Mm,
better. But really, that doctor doesn't know that they weren't given the tools to actually diagnose the patient.
yeah.
So that doctor thinks in their worldview that the patient is impossible, that chronic pain is chronic, and that they'll never get better. And so that doctor is like, ugh, I hate seeing these patients, or they're so difficult, they're so challenging. That doctor doesn't even know that their toolbox is without those things. So it's
Mm,
really this like big existential crisis of culture issue, an education issue, and then the deep roots of medical misogyny. So, what we're doing right, we have a lot of room to go. That's actually what it is. I think what doctors can do right in this moment, though, is just listen to the patients,
yeah.
and start coming at them with a sense of curiosity instead of, well, it wasn't in my textbook, so it couldn't be, right? Because if you understand that our textbooks don't include general anatomy, like there's so much variability in the standard textbook in gynecologic care. So if you understand that the system that exists is already like
Yeah.
you have to then understand, okay, well, if my foundation isn't sturdy, that then means that this patient with a symptom that I've never heard of or wasn't trained on or wasn't studied, it's not in the book. I should still believe the patient because now I know that my textbook was incomplete. I know
Mm,
that my training was incomplete. So that's what I think doctors can be doing better in this moment. Is just approaching patients with a spirit of curiosity. And then also PubMed is not free, but PubMed is available.
yeah.
Like go do some research. There are a lot of researchers out there trying to do the work, put in the work, but go read. Go read
Yeah.
around your patients. It's really, really important. Like even though you may not have gotten formal training, there are people that are publishing, myself included, that's constantly publishing so that doctors will read and learn something and then be able to translate that into their clinical care. So
Yeah.
Those are the things I think we can be doing better right out the gate.
Oh, yeah, absolutely. And I'm so glad that you mentioned research because you've said that research equals advocacy. So, why is rigorous science so critical to sexual health advocacy, especially for vulvar and menopausal care?
Something that I, again, was very fortunate to have was being a urologist. We have really strict guidelines around every disease state. At first, I thought that was kind of annoying because I was like, where's the art of diagnosis? Where are we like playing house? Like I love the show House, and
Yeah.
like everyone's a medical mystery. I thought having strict guidelines for everything kind of like takes away from that. But I realized that those guidelines are really protective because what it does is it standardizes care. Obviously, not everyone's going to fit into that standardized care, but what it really is doing, it's standardizing care, meaning that it's going to the literature and updating the literature all the time. So it means
Mhm.
that our guidelines are always as up to date as the research that exists. And the other thing about being a urologist is that they're constantly changing because we have a wealth of funding. That matters. That wealth of funding means that, okay, well, like I still remember when I started residency, after prostate cancer, no patient could get testosterone because there was a fear around testosterone causing recurrence of prostate cancer.
Mm.
However, many patients were suffering from low testosterone and the symptoms of it, and it was impacting their healthcare, and it was impacting their health, and it was impacting their quality of life.
Yeah.
So we had so many patients complain about it that we said, you know what, let's do a study. Let's start first doing the treatment, get small studies done, start publishing on those, aggregate those small studies into bigger studies, and then do a clinical trial. Like I learned the process of what it means to start research. You start with a couple of cases, you build upon those cases, so case series, you then, you kind of build upon it. And I think that really started my foundation of like medical discovery. So by the time
Yeah.
that I finished training, we were giving people testosterone after prostate cancer because we listened to the patients. We then translated that into research and then now have updated our guidelines where we are now saying it is safe to give testosterone to patients that after prostate cancer. That was within less than 10 years. Like
Yeah.
that's wild. Like that's what I see the power and the impact of research. And that just does not happen in women's health. First and foremost, women's health has a marginal funding compared to men's health.
Yeah.
Like that's just what it is. And then also, because I was given that framework of how research starts, you have to start with a question, you then have to start with a hypothesis, and then build upon that. Most gynecologists are like, well, if it's not a large scale, randomized, controlled, placebo controlled trial, it doesn't exist. And it's like, well, no, that's literally not how research works,
Yeah.
especially in an underserved and underfunded field. You have to first start doing the treatment, collecting the data, and then build upon that. And so I'm taking that framework of what I learned as a urologist, not what I learned as a urologist, I'm still a urologist, but how we do research in urology and to bringing that into women's health. Our case series started out with particularly the most recent research was I kept seeing that so many patients were coming in with recurrent UTIs that also had the same symptom as my vulvar pain patients. And I was like, I
Mm.
wonder if the vulva and the bladder are linked. Are we missing something? Are we misdiagnosing recurrent UTIs? It was a case series of about 250 patients. And it took over 3 years. And we showed that 85% of the patients coming in with recurrent UTIs and persistent urinary symptoms actually had a hormonally mediated vulvar inflammation that was
Wow.
caused by loss of testosterone. That's a small case series. And then we then built a database of 54,000 patients looking at a
Wow.
database. And then we found that like your risk of UTIs goes up by 44% if you've ever taken any anti-androgen medication. Like, yes, there's
Mm.
a lot of confounding data. There's all of blah, 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 all the things that you can talk about with research. However, we're starting the foundation that can then lead to a large scale clinical trial. But
Yeah.
if you're saying that your research trial doesn't count because it's not this large scale clinical trial, you clearly don't understand the disparities in research. And you clearly
Yeah.
don't even understand how research works and how you start research. And that is something that I try to be very diplomatic with a lot of my colleagues. One of the things where I will take out my earrings and you will see the Nigerian witch in me is the conversation around, well, we can't do those things and we can't help patients and we can't be imaginative and we can't be curious and we can't give women informed consent. because there's no wide scale, large placebo controlled trial. It's like literally
Yeah.
that's not how research works anyways, by the way. But I digress.
But I'm so glad you mentioned that, because I think a lot of people think research has to be starting out with the 54,000, and you have to have that huge number before it can count,
Yeah.
and so I'm really glad that you brought that up, because I think that is a widely misunderstood conception.
Yes, it's like, yeah, it's shocking. And it's so different from urology. I'm so glad I'm a urologist. I like there's a lot of things wrong with the field, and like I will also go on that to say that, but it really did set me up for success,
Yeah.
and just how I look at patients and clinical care and research and discovery and advocacy. Like it really did set me up. So thank you, American Urologic Association.
Yes. All right. I want to talk a little bit more about diagnosing. So, you're known for diagnosing extremely challenging sexual health cases. I think the term sexual health Sherlock has been used, and I love it. So, what is the first mindset shift that medical professionals need to make to become better diagnosticians?
Oh, get curious. That was something that my fellowship director really drilled into my head was get curious. He helps me to see the responsibility that I have as a physician, that
Mhm.
this person, this patient is coming to you for help. Your job, your only job is to believe them and figure out what's going on. If you haven't read about it, if it wasn't in a textbook, he helps me to see that our textbooks have such limited information. And just because it's not in the textbook doesn't mean it doesn't exist, because you have a real patient sitting right in front of you with
Right.
real symptoms. And so that that blew my mind. We're so rigid when we come out of training because we're like, I have this textbook, I know what I'm supposed to do. I'm like, and I'm taking all these tests, and like it should be in the textbook. But when you actually really look and step back and realize that that textbook isn't enough for the human body, the actual patient in front of you, you realize that, like, oh, I need to go back to the basics. I got to just learn what is the basics of how this body part works, what the structures are, how it works, and then all the things that can potentially go wrong, and then just get curious, stay curious. I actually do now get to be Dr. House. Like I get to
Yeah.
do the house thing, but I didn't realize that I needed a strong foundation of curiosity. That's really where the magic happens, is just staying curious.
Yeah. Oh, I love that response. All right. Now, vulvar conditions are often under examined and undertreated. So, what are the most frequently missed vulvar diagnoses or conditions in clinical practice?
Probably the most mixed condition is the loss of hormones to the vulva. So our
Mm,
vulva is both estrogen and testosterone dependent. There are certain parts of the vulva that require a lot more estrogen. There are certain parts of the vulva that require a lot more testosterone. And there's something that's very unique to women's health that drives me crazy, is that we spend a lot of time learning dogma and not facts. Most people, when we ask how much estrogen do women make in comparison to testosterone, the immediate knee-jerk reaction is, well, first, it's a deer in the headlights, because we've never were like taught what testosterone is. We were always taught about estrogen and progesterone, and
right.
no conversation, if at all, about testosterone. I'm asking you now, what is the comparison? And everyone immediately, their knee-jerk reaction is estrogen. However, our body makes 10 times more testosterone at any given life stage, at any given point in our cycle. That blows everyone's mind. And it
Yeah.
blew my mind. I remember my fellowship director asked me that like 4 or 5 months into fellowship, and I thought I was like good. I was like, I love this stuff. I know this stuff. And he asked me that basic question. I was like, God damn it, I have to go back to the drawing board. Like I like constantly humbled by this field, right?
Yeah.
Because we need both estrogen and testosterone to keep the vulva healthy. We need both estrogen and testosterone. We know that there are a lot of anti-estrogen medications that we can take that can impact our vulvar health, but a lot of people don't understand the impact of anti-testosterone medications. So
Mm.
things like acne medications, hair loss medications, even oral birth control, particularly oral estrogen contraception pills, progesterone pills as well, can impact the body's ability to either make testosterone or use testosterone, which then causes an inflammatory hormonal condition called hormonally mediated vestibulodynia. So that hormonal inflammation also changes our microbiome. So not only is our skin red, raw, and inflamed, our microbiome, which is protecting our tissue and our systems and preventing our urinary tract infections, is preventing vaginal infections, that then changes because of the change in the hormones. And so a lot of people are suffering from recurrent UTIs, they're suffering from recurrent vaginal infections, they're suffering
Mm.
and yeast infections, and they're suffering from pain with sex solely because of the loss of hormones. And
Yeah.
that's the coolest part about this is that once you replace the hormones, you completely break them of the cycle. So that's why I get so angry at the idea that we call these diseases chronic when in actuality, they are easily reversible. Like
Mm.
they're easily reversible and can be fixed and repaired. The other thing that upsets me is that we give these medications. Birth control is so important. It does a lot of good. However, it has side effects. And if we don't acknowledge those side effects, we then put patients into a cycle. We give you a pill. We say, this is going to help you with all these other issues. And then the patient comes in with a side effect. And we say, oh my God, every time I have sex now, I have a UTI. What's going on? And we say, I don't know. Maybe stop having sex. Gross. And it's like, actually, it's the birth control. We
Yeah.
can switch you to another birth control, or we can give you a topical hormone to like reverse the inflammation. So you can both be on the birth control and prevent symptoms. But we're not giving patients this choice. We're
Yeah.
essentially sending them down the path of like, wow, that's wild. You're just going to have to live with this and take antibiotics for the rest of your life or be in pain for the rest of your life. When all we had to do was just know basic function, know how
Wow.
it functions, know how different medications impact the vulva, and then know what the signs and symptoms are, and then know how to treat, which is essentially being a doctor 101,
Yeah.
being a clinician 101. But because we are not taught, there's a general attitude that these conditions are incurable and there's no reason to like even try. That's what patients are walking into. And patients don't
Hmm.
even know that that is the landscape they're walking into. They walk in thinking, okay, well, my doctor obviously went to school to treat me and they're telling me I'm incurable. I guess I'm incurable. Man, that sucks. Like in actuality, baby girl, like that doctor doesn't know that they didn't get the training. And so
Hmm.
they don't have the tools in their toolbox to help you. That's this like awful cycle. And I'm just trying to figure out ways that we can break this cycle, whether it's getting doctors to be educated or educating patients. We have to figure out how we break the cycle.
Mm, absolutely. And I think one thing that I've encountered is doctors who are not curious about like why things are happening. And they're like, here, we're going to give you this medication and it's going to stop the problem, but we're never really going to figure out what's going
Mhm.
on in the first place. And if
Yep.
you have side effects from the medication, well, it's better than the original problem. So it's okay. That is
Yeah.
super frustrating.
Yes. It sucks so bad.
Yeah.
Yeah. I've sat with thousands of patients and I've just heard their stories. And
Hmm.
I'm someone that those stories really radicalized me because I also saw myself in those stories in terms of like, I was the physician that was dismissing you because I didn't know that they had names when I was in residency.
Yeah.
I didn't know they had treatment like algorithms. Like, I didn't know, you don't know what you don't know. So that's also why I have a lot of smoke for the organizations, ACOG, CREOG, AMA, the people that I paid a lot of money to to
Hmm.
train me, and they didn't even train me on how to even diagnose, like how to even know about my own science around my own body,
Yeah.
right? Like, so I always try to lead with grace with physicians because I was
Hmm.
them, like I was them, and I was just so lucky to have done my fellowship and opened my eyes to how much I wasn't trained. I mean, all physicians should really be pissed about this.
Yeah.
Like, we all should be so angry that we are leaving training, we're trusting a system and paying a lot of money to the system and
Mhm.
sacrificing so much to a system that isn't even accounting for the science of half of the population fully. And I'll leave it at that.
Yeah, but well said. All right, I want to jump in and talk a little bit about menopause. Okay, so menopause is often framed as decline rather than a transition. And so, how do you reframe this for your patients and for other clinicians?
First and foremost, I think living is just a privilege. So, like, I'm always going to have a sense of awe at the human body. The way that we talk about aging in Western society is rooted in colonialism, patriarchal norms, and half of the population gets to age with dignity, and the other one gets to age and go gross, go like put yourself in a hovel, like ew,
In a
you
hovel.
know,
Yeah.
like the conversations around aging are very different. I think there's always going to be a fear around aging. Like a Western society has this real fear around aging. I
Yeah.
come from a non-Western culture where aging is seen as a dignitary state. It is seen as a sign of privilege. It's just like when you age, you get power in your community. So people want to age, like
Yeah.
in my culture. And so then to reframe that against Western culture and Western narratives, it's like aging is a shameful thing. And it's like, what? What are we talking about here? And
Yeah.
then if we get even deeper, half of the population gets to age with grace. They age like fine wine. And then all the issues that come with aging, they have really established pathways to help them, whether it's ED, whether it's hair loss, whether it's low libido. They have really awesome ways to help them with that. And the other half gets fed another narrative of like, gross. Like
I
just
know, right?
don't,
That's all. Just
don't
ew.
do that. Don't do that. Whatever you can do, just don't do that.
I know.
And then like, okay, well, I'm having hot flashes. I'm having night sweats. I'm having weight gain. I'm having fatigue. I'm having mood swings. They're like, gross. So not only are we shaming you for aging, the impact of what aging can bring to you, we're like, well, you can't actually get that access to care, even though the research shows that it is safe. This is where, again, how I research matters. And then not only doing the research, but then translating the research correctly to patients. Because if we looked at the WHI study, that was like that big study that scared a lot of people from ever taking hormones. The study actually was done well-ish. There were some issues, but it was the way that it was reported. The way that it was reported was this hysterical, yeah, hysteria, like old
Yeah.
school hysteria, which then led to this wide sweeping pendulum swing of not giving people the access to the potentially life-saving medications or life-altering medications that can help them in this transition. Yeah, again, it goes back to research. It's like, golly, if we don't have enough of it, but if it's then done, it's then not translated well clinically. We use a lot of fear-mongering tactics instead of saying, hey, this is the data. This is where the data is lacking. And this is your informed consent. You get to actually make the decision about your body based off of what data that we have. I'm also going to tell you what data that we still need. And let's figure out how to get you to your goals, whether that's quality of life, whether that's longevity, whether that's just like, I don't know, being able to sleep one night. Like, let's
Yeah.
get you there with informed consent. And I think that's what is really missing in menopausal care is informed consent, whether the doctor is not being informed on the safety and the efficacy of HRT, the patient's not being informed of their options, and
Yeah.
also the patient's not being informed of like menopause isn't a death sentence. It's a literal transition in life. And I will blame capitalism again for all of this shit. I love blaming systems because that's really what it is. Like,
Yeah,
I don't
it's
blame the
true.
individual, I blame the
Yeah.
system. And we're all just individuals working in a fucked up system. And my job is to shine a light on those systems, figure out how to break down those systems, and then get rid of people that are propping up the system. Actually, not get rid of them. I try to actually convert them back to my team.
Right.
Convert them to my team.
Yeah. And, I'm in a lot of different Facebook groups, about menopause and sexual health and things. And I see people who are terrified of hormone replacement therapy. They just say, if you take it, you're going to get cancer. There's this like huge gap of information, I think, that's out there.
Yeah, again, fear mongering. I don't have this level of fear when I mention testosterone with my testosterone patients, but then I have this level of fear around estrogen. We know that testosterone has a link with prostate cancer. We studied it, we looked at it, we count for it, and there's not this sensationalization around it. And yet We also know that estrogen and breast cancer can potentially have a link. Not every single breast cancer is associated with estrogen, but there's a sensationalization as soon as you mention estrogen. There's a hair, like a trigger of like cancer. And it's like, what are we
Yeah.
talking about? Our body's full of estrogen all our life, like until right now. So it's kind of wild that all of a sudden, when we're trying to give you the hormone that you've always made, it's now going to cause cancer. It's like,
Yeah.
what? I'm a big feelings person. I'm a very squishy, I
Hmm.
say I'm a woo-woo squishy surgeon.
Yeah.
However, feelings over facts, when those feelings are impacting access, healthcare, health, we can't do that. We have to
Hmm.
lead with facts in this realm. And yeah, give informed consent.
Absolutely. All right. So, one of my last questions for you is about clitoral nerves. So, what do you wish more professionals understood about clitoral anatomy, function, and clitoral nerves?
Oh, the clitoris. I think the reason why that research struck such a nerve internationally, it was kind of wild. We did not think that that was going to get the press, the activism, the push that it did, the exposure that it did, which is just so awesome to be a part
Yeah.
of that. I always have to shout out to the other authors like Dr. Paige Isabay, who is a gynecologist in Canada, and then Dr. Blair Peters, who's a gender affirming surgeon and a nerve surgeon at OHSU. Like that was the three of us just getting together and seeing the gap and wanting to fill it in. Two things that come up for me is that most clinicians leave training without even knowing how to examine the clitoris. We just know it's there. With the clitoral nerve paper, we also wrote a paper about the medical neglect of the clitoris. And
Yeah.
it's deeply rooted in medical misogyny and cultural misogyny and sexism, racism, all the things, right? It's deeply rooted in that. And I think that's why that organ has such a powerful battle cry. Hopefully, what clinicians look at it is, wait, why don't I know how to examine the clitoris? Wait, why did
Mm.
it take until Dr. Helen O'Connell, who was a urologist, why did it take Dr. Helen O'Connell until the 2000s to actually map out the full clitoris? Why did it take up until 2023 for us to get the nerves? Like, why is that? I want people to get really curious. And I hope they also start seeing, like, well, if we didn't know that in 2023, what else don't we know? A
Mm.
lot, team. A lot.
A
We
lot.
don't know a lot. And so I hope that they take that curiosity and start saying, well, okay, if my foundation of knowledge isn't complete, that then means that the patient coming with a symptom that I've never heard of might actually be legitimate. And it's actually me that
Mm.
doesn't know enough. And I should go educate myself. That's a big wish, a big ask for patients or for physicians. But that is kind of what I hope is that starts to uncover the narrative that like all science is complete.
Hmm.
Science is barely complete, especially around women's health. So when that patient comes in with symptoms that you've never heard of before, it's not the patient's fault. It's actually American Medical Association fault that didn't teach you these things and that doesn't standardize how we learn about women's bodies. Like
Right.
it's that, and then write to them, get angry, write to them, and say like, I demand that we reform our education model because I, as a doctor, took an oath that says first do no harm, and I'm doing a lot of harm because you are not teaching me about
Hmm.
basic functions, basic
Yeah.
anatomy, basic physiology. But I digress.
No, but very well said. All right. So we're going to close things out with a lightning round. So
Okay.
I want you to say the first thing that comes to mind. So we're going to start out with a fun one. If you could have one superpower, like X-ray vision for pelvic floors or a magic wand that instantly cured vulvar pain, what kind of superpower would you choose?
Getting everyone affordable healthcare.
Okay. Yeah. All right. I feel like we just need to stop now. No, that was perfect. All right. Okay. If you could erase one piece of misinformation from the internet about vulvas, what would it be?
That it is normal to get recurrent UTIs every time that you have sex.
Good. All right. What's one test you see ordered way too often?
One test I see ordered way too often is mycoplasma and ureaplasma. And this is a very special test for urinary tract infections and also vaginal infections. And it's literally like a test of like, I don't know, I've tried everything else. I've looked for everything else. Let me just look for that. And it's oftentimes not ureaplasma or mycoplasma. You might find them, but really mycoplasma and ureaplasma, to me, what I hear when I see that is my vulva is unhealthy because why is it that mycoplasma and ureaplasma can grow here? There's an
Mm.
underlying issue that's causing it. And it's most likely that there's a hormonal imbalance, predominantly, most likely testosterone, because we give a lot of anti-testosterone medications without thinking of the long-term impacts of it. And so when I see mycoplasma and ureaplasma, I don't think that's the issue. I think that is a symptom of a deeper issue.
Mm.
That's that's a
Yeah.
test that I think is ordered way too much.
Yeah. So interesting. All right. Now, if you could assign one must read, either a book, research papers, type of publication for sexual health clinicians, what would it be?
When Sex Hurts by Andrew Goldstein and Erwin Goldstein, and then Dr. Jill Kraft. That's a really fantastic framework for clinicians that want to learn an algorithm. And then our new paper that's coming out, looking at the high rates of misdiagnosis of recurrent UTIs and the actual impact of what it looks like to have a testosterone deficiency potentially causing your UTIs.
Yeah.
Journal of Sexual Medicine is coming out in the next couple months.
Oh, I love it. Let us know when it comes out so we can share it with our community for sure. All right. And last question. If you could leave one message for the next generation, so like our Gen Zs, our Gen Alphas, about sexual health, what would it be?
It would be, you're going to have to become your own biggest healthcare advocate. You're going to have to be the one to educate yourself on your own body, because the healthcare system is failing you, and the healthcare system has no interest in righting this wrong just quite yet. It's actually going to take outside pressure to get them to care. And so the more that you educate yourself, the more that you can advocate for yourself, and the more that you can put pressure on the system that refuses to change, that refuses to see you, that refuses to see your suffering, that refuses to train the doctors that took an oath of first do no harm the right way so that we can then do no harm, you're going to be the one that changes the healthcare system. And I will be right there with you with my pitchfork and my torch, ready to burn it all down so that we can build again.
Yeah. Oh, that's so powerful. I love it. All right. Now, real quick before we go, you have presented with Sexual Health Alliance before. So I'd love to hear a little bit about what you thought about being a presenter with Shaw.
I love it. I love sex. I love sex in all its, like, I love the science behind sex. I say my job is taking people from pain to pleasure. I love that I can get so nitty gritty and nerd out around the physiology around sex. And then I can then also get the pleasure in the kink space. Like I can get all of that within one thing. And the other thing I really love about sexual health is it's a team sport. How cool is my job that I get to work with sex therapists, sex educators, tantra workers, sexological body workers, physical therapists, so many more people. And there's so many more that I haven't even met yet. And I'm so excited to like do this cross collaboration and to work with people who are touching sexual health and touching patients' lives in just different ways and realizing how we are all interwoven and connected is just so cool. And then the community is always so curious, so excited to learn, and so welcoming. I love it.
Oh, I love hearing that. That's fabulous.
Yeah.
Oh, so wonderful. It was so great to talk to you, Dr. Maria Uloko. Thanks so much for being with us today, and we cannot wait to talk to you again soon.
Yay. Thank you so much for having me.
All right. Bye, everyone. Don't forget to subscribe on YouTube, Spotify, Apple, or wherever you listen. Links are in the description below.